In this segment, we're going to talk about the new hemodynamic definitions that were discussed at the 6th World Symposium on Pulmonary Hypertension, and in specifically how they affect the classification and treatment of adult congenital heart disease. So the proposed clinical classification of pulmonary arterial hypertension associated with congenital heart disease can be divided into 4 segments. There are those patients with Eisenmenger syndrome. They have such severe pulmonary hypertension that their shunt flow has reversed and is now going right to left instead of left to right. So that group is obviously a group that can't be repaired surgically. The second group are patients with left to right shunts. So they may have pulmonary hypertension, but still primarily be shunting left to right, or may have more mixed flow. And sometimes those patients can be corrected, but sometimes their pulmonary vascular disease is too severe and they're non-correctable. Group C is considered pulmonary arterial hypertension with coincidental congenital heart disease. So this might be a patient with a PFO or a very small ASD that is not thought to be the etiology of the pulmonary hypertension. And then group D are patients with postoperative pulmonary arterial hypertension. So these are patients with congenital defects who perhaps were operated upon a little bit late, or perhaps many, many years after their operation develop pulmonary arterial hypertension. And we see this actually not infrequently in our adult populations. The previous definition of PAH was based on a mean pulmonary artery pressure of greater than 25. And of course, the new definition is going to be a mean pulmonary artery pressure of greater than 20. But in addition to the mean pulmonary artery pressure, the pulmonary vascular resistance provides essential information, particularly when we are considering whether or not a patient can be surgically corrected. So there are many things to consider when we are determining whether or not a congenital defect can be closed in the presence of pulmonary arterial hypertension. The long-term impact of defect closure in the presence of PAH with increased pulmonary vascular resistance is unknown, and there's quite a bit of gray area in this decision-making process. I think that most people feel comfortable closing a defect if the pulmonary vascular resistance indexed is less than 4 Wood units, and so the PVR is generally less than 2.3. And I think on the other hand, when the PVR index is greater than 8, corresponding to a PVR of greater than 4.6, we feel very concerned about closing that defect. If you close a defect in someone with that much pulmonary vascular disease, the right ventricle, which is used to having that offload, might struggle pumping against that very high pulmonary vascular resistance, and such a patient might come out of the operating room with more right ventricular failure than when they went in. And generally, that's the cutoff, about 4.6 for a PVR. However, the gray area is for patients with a PVR index between 4 and 8, so generally a pulmonary vascular resistance between 2.3 and 4.6. And that needs to be determined on an individual basis. And there are many things to consider. I find it very valuable to look at the echo and look and see how the right ventricle is functioning. Other things to consider include the patient's age, the type of defect, all their other medical comorbidities, whether or not they desaturate. This is really important information. If they really need that shunt, if they really need that pop-off when they walk, that tells you the right ventricle likes having that pop-off and might really struggle if you close that defect. So if you do a hall walk on a patient who falls into that 4 to 8 Woods units for their PVRI, and their saturation goes down from 95% at baseline to the low 80s during the hall walk, that really tells you that that patient needs that shunt to function well, and that might not be the right patient to consider closing. And then there's the whole concept of PAH therapy with an intent to repair. And while some of us do this on an individual basis, it's not really been proven. It might be something to consider in a patient who's in that individual gray zone area or you might treat them with PAH-specific therapy and then recath them and see if their PVR is much lower, see if they desaturate less when they walk, and if they do, you might consider closing them, but really this is an area that's not been adequately studied. So when it comes to congenital heart disease, we've changed the definition, we've lowered the threshold for pulmonary hypertension, but as we decide which patients might be candidates for surgery, we need to take into consideration not only that, but the pulmonary vascular resistance and many other things, including how much they need that shunt, particularly when they exercise, how much they desaturate. So this has been a bit of an update on congenital heart disease, hemodynamic classification, and how to decide who might be a surgical candidate. Thank you for joining me today.